All right, Dr. Penny Figtree, thank you for coming on the show.
Thanks for having me, Max.
All right, I'd like to start with a little bit of a thought about this basically epidemic of chronic disease, rising prevalence of obesity, metabolic syndrome, diabetes. What, in your mind, as a doctor, driving this increase?
It's interesting, isn't it, Max? Because you think back to the 1950s and you look at all those pictures, and no one seems to be sick or overweight at the beach. And the GPs weren't spending their life treating chronic disease. Like, you can't get into a GP now, and it's because they're booked out with diabetes and writing scripts for blood pressure medication. Whereas in the past, you were just doing appendicitis and broken legs. So it's confusing because they did have takeaway food back then. They still had milkshakes and things. But I do wonder if it's because they forced us down the low fat idea. So really thinking that fat is terrible. And so the processed food industry started making the food without the fat in it, which ended up being refined carbohydrates. And so everyone started eating more carbohydrates, and they don't make you full, they make you hungry. And I don't know if you know about that carbohydrate insulin model of obesity, which if on Twitter everyone argues about all the time, but it really makes sense to me. And that is that if you're continually eating rice crackers and breakfast cereal and breads, every time you eat them, it spikes insulin. And the more you have insulin in your blood, the more insulin resistant you become. So people, insulin drives insulin resistance. And so people are snacking all the time, eating all the time, these refined carbohydrates, spiking insulin constantly. The cells then become resistant to that insulin. So then your pancreas makes more insulin, even when you're asleep. You've got high insulin, which again drives insulin resistance, and that's metabolic syndrome. So metabolic syndrome is pretty much high insulin. It's a disease of too many carbohydrates, which have caused high insulin. So if you pull out carbohydrates, you reverse metabolic syndrome. So I do think this whole epidemic is coming from too many sugars and starches because everyone thought that was healthy, spiking insulin and causing insulin resistance. I know it's probably multifactorial. Like obese women have children that are then obese, so it's spreading into the next generation. Social problems, yes, it's complex, but I do really think it's refined sugars and starches and people being scared of eating an egg. Gosh, don't want to eat an egg, but I'll have 5 pieces of pizza. When people are always worried about eating meat, they're going to die if they eat meat. But, when I go and buy petrol, no one offers me 6 lamb chops, do they? They offer me 6 Mars bars. And that's the problem. That's what I think.
Yeah, no, I agree. And I think that in the absence of nutrient dense animal fat that you would find on their steak or eating the full fat dairy, people have a need that's unmet and they will seek alternatives. And unfortunately, those alternatives are energy dense foods that are rich in sugar and soaked in vegetable oils, which are an attempt to fill a gap that was left by fatty animal foods.
Yes,
So,
that's right.
so you have this situation where all these patients are coming in with chronic disease problems. From a doctor and a general practice point of view, how are these patients being managed or cured? Are they being cured or are they being managed? I guess I'm kind of putting words in your mouth there.
Yeah. It's a bit, sometimes as a GP, you can get a bit sad because you've known people for a long time and everyone hits 40, 50 and you watch them getting sicker and sicker and it's due to food. And you start with the blood pressure pill and you're watching and then, it's diabetes and it's just heading into misery. And so what general practice does is just prescribe pills. So you just keep prescribing pills and pills can't fix what the food is causing. It can patch it, but you essentially just watch people get sick and have a miserable life. And it's quite devastating, really, because everyone, where's the well person? Spot them. I can't find them. And so general practice is full of these people. And how on earth is the medical system meant to deal with that? It isn't. It can't you can keep paying more money and getting more pills for this and that, but it's just a disaster. And you can just see it now. There's a disease called fatty liver disease, and everyone's getting that now, so much so that they've moved the laboratory test up, because otherwise the gastroenterologists will be booked out with people with fat in their liver from sugars and starches. And the pharmaceutical industry, they're searching, we're looking for a drug for fatty liver. And you always read about it, they're trying to find a drug for fatty liver disease. And you just can't believe it, because you've got a blood pressure for tablets for high blood pressure, diabetes, fatty liver, and people come in they're on 8 pills. It's just terror, and then they're depressed. And so everyone is the same, and they've got sleep apnea, so there's that machine. And so you just sit there as a GP writing scripts for all these pills, and the person keeps coming back every 6 weeks, and you do a blood test and you monitor it. So you monitor them dying. That's what you're doing. Monitoring the diabetes getting worse, monitoring the blood pressure up the pills, monitoring the people getting more overweight. And it's pretty desperate. And the only way to fix it is food. You can try pills, but it's just a disaster. It makes you despair, to tell you the truth.
Yeah,
Yeah.
I mean,
So
it does sound like witnessing a slow train crash, a train crash in slow motion. And
yeah,
you mentioned that it's increasingly becoming normalized by the fact that reference ranges for what would previously be abnormal biochemical markers, like liver function tests that give an indication of early or fatty liver disease, they're being moved. So that, to me, it sounds like the profession or the conventional approach is so much either blind to the problem or so defeated that they're not even able to admit something that's staring them right in the face.
yeah. I think they're blind to the problem. I don't think the doctors are bad.
Mm.
I don't know, they're just so just look at pills. I think the reason that is because until you've started using low carb in your practice, you know that lifestyle doesn't work, because I've tried forever
Mm.
with lifestyle. And
Mm.
so everyone knows lifestyle doesn't work, and everyone's given up. And so we're just hoping that the drugs will be the solution. And I must admit, there is one drug that is seeming to work quite well, which is that semaglutide or Ozempic. These are GLP-1 agonists. So they
Mm.
might have hit on something good there.
Mm.
Um, but you can't give everyone a drug. But so I think they just see it as drugs. I used to think being a good drug prescriber was my job, but that was because I tried lifestyle. I tried OptiFast. I tried 5-2 fasting. I'd pretty much given up. I just said to people, just don't lose weight. Let's just try and, don't gain weight. Let's get you to
Mm.
maintain your weight. And so I'd always be watching it, but you're always losing
Yeah, I mean,
until, yeah,
sorry, go on.
until you start using low carb, and then it's like a miracle.
Mm.
That works. That works.
Yeah, and I mean, to me, that just states that the advice that we're giving patients is just ineffective.
Yes, it
Yeah.
is. It is actually, like whenever I see patients, so people come to see me for low carb, for weight loss and diabetes, and they've tried everything, and they're not unhealthy. Like they think they're healthy. Everyone's having porridge. They're all having a banana with light milk and a low fat yogurt. They're all having multigrain bread on their sandwich. They're not eating pizza, but they're
Mm.
they're not getting anywhere. They're not getting
Mm.
anywhere. And the minute you just switch that bread out and an egg in for the cereal, they're fixed. Like I had a man the other day on a lot of 30 units of insulin, and just by getting rid of his porridge, we got him off insulin in a day.
Wow.
It was the porridge and the bread on his sandwich,
Yeah.
and that was enough.
Mm.
But if you'd gone to a normal dietitian, they probably just say, "Oh, I don't know, you're doing really well,"
Yeah.
because he's
Yeah.
eating fish and all the right things. So yeah. Anyway, I
Mm.
think normal doctors just don't know. They're just despairing,
Mm.
and then of course they think they're drug prescribers. That's their job.
Yeah. So you've gone from a transition, a rebirthing, perhaps, from a doctor who was operating and prescribing and practicing in this traditional paradigm to now a doctor who's focused on lifestyle and is having an amazing results. So can you describe a little bit about that transition for us?
Yeah, sure. So have been in general practice for about 20 years, and I feel like I'm a good GP. I always take time with my patients, and I'm a holistic. I felt like I was holistic. Um, so I was always interested in weight loss and healthy diets because I knew that was the cause of all these problems. But as I said, I had given up, but I was still curious, and I was interested. There's a guy called Volta Longo. Have you heard of Volta Longo? He's a doctor in America who does fasting. He's got something called the fasting mimicking diet. I saw him on the Michael Mosley Horizons program about fasting. And I used to love Michael Mosley as well. And so I try all those things. And I was into this Volta Longo fasting. And I went to my physio. I had a sore back. And she was telling me about her husband who'd lost lots of weight listening to a guy called Jason Fung, who was also into fasting. And so I was going, oh, we all have to be vegan pescatarian. This is what Volta Longo says. I was telling her she was all wrong. And so then I went back and I listened to this Jason Fung podcast and bought his book. And then that led me to David Ludwig's book called Always Hungry. I don't know if you've read his book, Always Hungry. So David Ludwig's he's a pediatrician and he works in obesity. He's a famous obesity guy. And his book, Always Hungry, those first few chapters, it was like, it just opened my eyes. Because he's the guy that talks about insulin and the carbohydrate insulin model of obesity. And it just makes sense. Every time you eat bread, ups your insulin, and insulin's the fat fertilizer. It promotes fat storage and it inhibits fat breakdown. So if you keep the foods out that spike insulin, then people can lose weight, effortlessly. And then that led me to this guy called Eric Westman. And he's great because he treats patients that are like my patients. So he's a doctor at Duke University and he runs an obesity clinic and he's been doing this forever. Plus, you can watch all these videos on YouTube. So you watch how to do it. I call it the white coat video, and it's him sitting in a white coat explaining to patients how to do this diet that keeps your insulin low. It's very low in carbohydrates. And so I watched that, and I got his diet sheet. And then I tried it on a new patient. I had a woman, she had palpitations. She was out the back in the treatment room and she was overweight. So I'd never met her before. And I said, do you want to try this diet and see if you can lose some weight? She said, yes. How much weight do you think I could lose? And I just made it up. She said, do you think 10 kilograms? And I said, yes. But I had no idea. And so I just pretended I was Dr. Westman and explained the diet to her. And then she came back a month later. She'd lost, 5 kilograms. And I still remember I put her on the scale and she cried and I cried. And it was like a miracle. It really was. And the thing is, it just kept working. So then I did it with another patient who's a regular patient. And again, she came back at 2 weeks. And it's like a textbook. She said to me, I've got my reflux is gone. My hands don't hurt anymore. I don't need to sleep in the afternoon and I'm walking every day. I've got so much energy. And it just kept being, every time I did this, it was like a miracle. And then I'd be stopping their blood pressure pills. And never in my life have I turned up at a sporting match and had a patient come up and say, oh, thank you, Penny, for that diet. My irritable bowel is gone. I'll never stop it. It's not about the weight. It's about my irritable bowel. And see, this is me on my own. Like you can read it on the internet, but I discovered this before I'd read this diet fixes irritable bowel. And so it is like a miracle. And I love it. I love it. It's so fun. It's gone from misery to give me that person. I love the sickest of the sick. The more pills, the better, because they love it and I love it. And it is like a miracle. It really is and I wish if every dietitian and every GP did this, you'd fix a third of the people. Okay, some people can't do it, but so many people can. When you say you can eat eggs and meat, they can't believe it. They're so happy. Every day. And I remember a woman who said, I'm going home to cook prawns in garlic butter. So, they're sort of excited about food again instead of having to eat, lentils, chickpeas, quinoa, and foods that, aren't. I mean, some people love them, but other people love steak and yummy buttery sauces. So anyway, that's me. So that's what I've been doing for, I don't know, 4 years.
Yeah, and I think I had a chat to Dr. Rob Sabo, and he called it a gaslighting of patients, which is just
Yes.
decades of narratives that have emphasized or demonized a certain group of foods that we have been eating, what I presume, for millions of years in our evolutionary past. And we've just been told not to eat them. And it's fascinating that when you tell a patient, yes, you can eat this nutrient dense food that tastes great and is also healthy for you, not only are they happy in it and with the taste, but they're getting such amazing results as you just described. In a conversation we had before, you mentioned one patient to me who had 4 or 5 specialists for each of her different organ systems and
Mm.
organ problems. Are you able to recount that story for the listeners?
Yeah, sure. Because I think what we're doing at the moment is not only do we have a different pill for every single part of the metabolic syndrome, which is one disease, but we've got a different pill for each symptom. We have a different specialist for each system. You've got your gastroenterologist for your fatty liver and your reflux, and then you've got your endocrinologist for your diabetes, and this particular woman had a neurologist for her migraines, and so there's this a flourishing of specialists to treat all this metabolic syndrome as well. How powerful if in the next month everything changed and everyone went low carb. Well, there'd be a lot of unemployed doctors, I reckon. Um, so yes, this particular lady, she's moved to our town and from Sydney, and she had all her specialists in Sydney for her metabolic syndrome, and she had a renal doctor for her kidney failure. And so she was on insulin, and so she was off her insulin. She's off 2 of her blood pressure pills. Her fatty liver's getting better. She's feeling so much better, and she went back to her kidney doctor, who just couldn't believe that she was doing so well. Thought she'd be acidotic, because you'd think, you're putting someone on a ketogenic diet and that she'd get metabolic acidosis, but of course she wasn't. And so her endocrinologist couldn't believe it. She's off all her insulin. Her HbA1c is 5.2% on no drugs at all. And this is someone who's been on 50 units of insulin for 10 years. She was on rapid acting insulin with meals plus a long acting. And her blood pressure is amazing. And she'd lost some weight. But to me, the weight loss I don't really care. I just love people's feeling better and their blood tests getting better. And so, but I often see patients like that. Like, I've got another woman who goes to a posh hospital in Sydney, and she said all they do is monitor me. They just monitor me getting sicker, but they don't actually do anything. And now when she goes back, they go, "Oh, your liver tests are normal," and they don't. And when she mentioned the diet, she said their eyes just glazed over. They weren't even interested. But that's why I love the sick people, on all that insulin, because if they can do it, most people can get off insulin. Some people need to stay just on a little bit because maybe they've had diabetes for 30 years and the pancreas can't make enough insulin, but still they're on much less insulin. But the majority of people can get off it. So it's really quite fun to do it because they can't believe it. A man the other day said to me, if it was just what I eat, why was I ever on insulin? If it's so easy, why was I ever on insulin? And that's exactly right. No one should be on insulin if you're a type 2 diabetic. You should never get there. But unfortunately, GP education is all about insulin initiation and intensification, not telling people that if you're on insulin, you increase risk of dying. You increase your risk of dying. Like, people on insulin die more. It's not a good thing to be on. You want to be on the lowest dose you possibly can be. So anyway, I think that was that lady. Is that the lady that I told you about? Yeah.
And just for listeners' understanding, insulin therapy is used in type 2 diabetics,
Yeah.
with the goal of controlling blood sugar. So injecting insulin will bring your blood sugar down, but your circulation is still bathed in insulin, and you're still profoundly insulin resistant. So
Yeah,
insulin injectable is necessary for type 1 diabetics who don't have ability to make their own. But for
exactly.
patients with type 2 who have working endocrine pancreas, then you're simply just adding um, more insulin into a situation where you're overflowing with this hormone. And
Yes,
obviously, what Dr. Penny is talking about, and what she's had so much success with, is that if you remove the stimulus, the need for insulin secretion, by not eating sugar and starchy foods, then that demand for insulin drops, and your blood sugar can normalize, and you no longer need to inject it. So it's just a nonsensical or illogical practice in our mainstream medical approach, that we're treating a hyperinsulinemic patient with more insulin.
yeah, exactly. And insulin drives insulin resistance. Like it's part of the problem is the insulin. So, because these people have got too much insulin in their blood, like you say, and that's causing insulin resistance. And then that feeds back in a vicious circle. And because they're so insulin resistant, that's why they come in with more insulin to overcome that terrible insulin resistance, which just drives more insulin resistance. And so people end up on higher and higher doses of insulin, which is driving the disease. So no wonder it's a chronic progressive disease, making people sick. And then if you just stop sugars and starches, then you don't need that insulin to get the sugar into the cells. So you can pull that insulin out, and then people get more insulin sensitive and they lose weight, and you sort of start undoing the damage and get people back to normal. I always say you can have wheat bix and insulin for breakfast, or you can have an omelette and no insulin. That's how easy it is to stop insulin. Just don't have, you can have wheat bix and insulin or an omelette, and people, that's why patients go, oh, why has no one ever told me that? They don't understand. You're just injecting that insulin for the glucose in your food. So why don't we just pick foods without glucose in them? And it's not even clever. I sometimes think the scientists, they're being very clever. They're all talking about receptors and molecules and cellular membranes. And you just need someone to stand back, like, David Unwin just stands back and says it's just soon to be sugar food, so don't eat that food. It's really simple. You don't need to be clever. It's very simple.
And I want to make a mention too of another state of hyperinsulinemia that is what I believe inappropriately treated with supplemental or exogenous insulin, and that's gestational diabetes.
Yes,
And
yes.
and Penny, tell us what is your perspective, or have you treated patients with gestational diabetes, and how have they been on a low carb approach?
Okay. So interestingly, there was a diabetes conference up in Queensland not long ago. Did you know that? The Australian Diabetes Congress. And we had a poster there. I had a medical student go up and we had a poster, wasn't presented, but a poster about chronic kidney disease and low carb. So I looked at the program. I was going, where's the bit on diabetes reversal in this diabetes conference? Nothing. Okay, where's the bit on low carb? They had one little session on low carb. So the medical student went along to the session for me, and there was one dietitian who's doing a PhD into gestational diabetes, and her talk was about how you shouldn't do low carb for gestational diabetes. I think the other one said, oh, you could maybe give it a go, and they're all on the one was don't do it, and the other two are like lukewarm. I just don't understand. It's like, guys, this is your thing. You could change the world. Why are you not excited? But yeah, so it was cautioning against it. And I just thought this is shocking because there's actually a gynecologist in Queensland, Tim O'Dowd, who is specialising in low carb, and he treats gestational diabetes. He's an obstetrician gynecologist. So he now just does low carb for women, and he'd be doing gestational diabetes. He's there. Why was he not there giving a talk at this conference? No, we just had someone doing a PhD saying don't do low carb. And so it made me upset. So I actually haven't had any patients with gestational diabetes, but there's a book and there's a woman, and I can't remember her name. Do you know
Is
the
it
name of that?
Lily Nichols?
Yes, I've got her book. And
Mm.
so any pregnant women, I've had some pregnant women who've got pregnant going low carb. I give them her book. And of course, why would you not be doing low carb if you've got gestational diabetes? I don't
Yeah,
even see why you wouldn't be.
yeah, and
So anyone
mm,
who's watching who's got gestational diabetes, get Lily Nichols' book and do
mm,
what she says.
yeah,
Because I think
and
in Czechoslovakia they use her book.
really,
Yeah,
mm.
or somewhere in Europe. Yeah.
So for the listeners, so gestational diabetes is basically some women in the process of pregnancy become insulin resistant, and often it's a indicator or a kind of prelude to becoming type 2 diabetic later in life. It's a bit of a warning sign, and often they can be a little bit metabolically unwell prior to the pregnancy, and the pregnancy is unmasking this state of insulin resistance. And at the moment, there is some dietary advice given to women with gestational diabetes, but just like conventional new dietetics advice, it doesn't involve cutting the carbs down, which, as you've just heard Dr. Penny talk about, is highly effective. So you have this situation where women end up progressing to needing insulin for gestational diabetes and then are instructed to eat more carbs because they're on insulin. And problems like uh, fetal macrosomia, so a large fetus, are related to the high insulin circulating insulin levels, not necessarily the blood sugar per se. So
Mm.
we're harming these women, or they're harming these women by not providing advice to cut down our carbs, so that we can avoid as much as possible the use of exogenous insulin. So I just wanted to make that point, as relevant to a younger audience, that
Yeah.
metabolic dysfunction can manifest in all people of all ages, and it's all very, very receptive and responsive to a low carbohydrate approach, as
Yeah.
Penny has mentioned.
I think the placenta makes you more insulin resistant, and so that unmasks any underlying insulin resistance that you might have. It just gets worse. But doesn't it just make sense? You eat a bit of bread, your blood, it turns into glucose in your bloodstream. So you have insulin to push the sugar in, but you're so insulin resistant that it doesn't work, so your blood sugar
Mm,
goes up.
mm.
So don't eat bread.
Yeah, and also I want to make a comment about the polyunsaturated fatty acids. So an excess of dietary linoleic acid is also, there's strong evidence that it induces dysfunction of your fat cells, and that is promoting a state of insulin resistance. So if you're having your fat tissue is composed of all these oxidized fatty acids and oxalams, which are breakdown products of linoleic acid, then your adipocyte, your fat cell, is malfunctioning, and then you're adding on starch on top of that in that already broken metabolic system, and you're exacerbating this insulin resistance. So that's how I like to think about it. There's kind of a lot of different ways that contribute to the initial breaking of our metabolic health and development of insulin resistance, but any any dumping or eating of carbs, starches, and sugars on top of that will make it worse. So removing them obviously makes it a lot better.
Yeah.
Mm,
And look, a lot of, you know how everyone blames saturated fats for everything?
mm,
And they'll go, well, serum saturated fats are associated with insulin resistance, like quite
mm,
strongly.
mm,
And so then they'll say, oh, don't eat saturated fat. But the saturated fat hasn't come from your steak, it's come from the sugars and starches, which are turned into fat in your liver, and then the liver ships them out. And so that's where the saturated fat in the blood has come from, not from your food. And
mm,
that I think a lot of scientists don't even understand. Um, and thinking of, and I just think that's such an important point, because a lot of people, endocrinologists, will say saturated fat causes insulin resistance, and you have to
mm,
say, where did the saturated fat come from, guys? It came from the liver and the sugars and the starches. And
mm.
that's what we all eat. Foie gras, which is fatty liver, isn't it? And how do you get foie gras? You give the poor animals corn and figs, don't you?
Grain.
Force
Mm.
and grains. How do you fatten them up with grains turned into fat? Anyway, that's a message I always feel lots of people forget.
Yeah, and I really want to emphasize this point, which is a disconnect between theory and science and empirical reality of clinicians like you, Penny, who are treating patients. And there's massive body of guidelines and recommendations based on theory that saturated fat is going to cause heart disease, which is now quite thoroughly debunked. And then we have your experience, which is you take away all these forms of refined foods. You put a patient on a very meat heavy diet. Do they get diabetes? No, of course not. Their diabetes actually reverses. They lose their liver fat. Their waist circumference decreases. All the biochemical markers of metabolic health, like HbA1c, fasting insulin, triglycerides, all decrease. HDL improves.
Yes.
So all the holistic picture is improving. Yet perhaps maybe total cholesterol is going up, there's still a degree of inability or reluctance to understand or appreciate the totality of the direction, which is away from the cliff, into the metabolic abyss, and back to safety. I mean,
Yes, I know. It's fascinating. There's a guy on Twitter who's a super Harvard epidemiologist. I wish I could remember his name, but he's some champion. And someone put a picture up of a hamburger and he wrote down that's how unhealthy it is. And someone wrote, well, it's just the bun that's unhealthy, but the rest of it's all right. And he wrote, I know, as a Harvard epidemiologist, I know meat causes diabetes. I wish I'd saved that tweet because I it doesn't make you despair. He's the cleverest of the clever at Harvard and he thinks meat causes diabetes. And you want to go, have you not seen Sean Baker? He just eats meat. That guy is a carnivore. He doesn't have diabetes. I give my diabetics meat and they get better. How many cases do you need to disprove your theory?
yeah,
And these are the clever people that everyone goes to the conferences and listens to. But just come and sit in my office and watch all the people get better when they start eating bacon and eggs and steak for dinner.
yeah. It's that the distinction between the practitioner and the theory and practice. What did
Yeah.
Yoga Berry say? In theory, there's no difference between theory and practice, but in practice, there is. Um,
Okay.
so,
Yes.
but I mean, it's a fascinating point, and it kind of to me it reminds me of was it Semmelweis was the obstetrician who first proposed washing one's hands after dissecting a cadaver was a good idea before delivering um, a baby, and he
Yes.
did a short study and was able to prove a reduction um, in postnatal or peri antenatal fevers and birth infection by just simply washing his hands. And the tweet
Mm.
that you mentioned, I mean, it sounds like a colleague of Semmelweis saying, I'm a respected professor. There's no evidence that hand washing has any role to play in development of infection. So, I
Mm.
mean, it's this sclerotic nature of science in my mind,
Mm.
and these embedded concrete paradigms that often aren't able to be broken until people pass on
I
in
know.
such
It's
cases.
so true. And
Mm.
it's quite terrifying. It's actually terrifying because it's so obvious. Like, this isn't subtle. This is not, these are people crying, the doctor's crying, the blood tests are amazing in weeks. It's not like a day. It isn't like years and a slow moving. It's rapid. And yet it's not accepted by mainstream. And you can see why you need people from the outside to come in and shake things up because everyone just goes along to conferences and agrees with each other. And if you try and disagree, you're weird. I have a friend who's an endocrinologist who said, Penny, you're going to get sued. You're crazy. You shouldn't be doing this. This is an endocrinologist. I sent him articles. Oh, that's there's a reason why that wasn't right. And you do despair, and it does turn you into a slight conspiracy theorist. So there's a lot of anti-vax, low-carb doctors, and I think it's because you start losing faith. You don't trust the system anymore because we could fix all these people, and none of them are being fixed, and it's so easy. So you have to be careful not to become a conspiracy theorist.
I think the patient themselves, though, if they have gone through this process of having been given incorrect dietary advice for so long, become metabolically unwell, eating porridge as they've been told, being a compliant and good patient, and then going through this process of reversing their metabolic dysfunction with diet, that's enough to be skeptical and to almost feel, I mean, resent even that you've been given the wrong advice. So
I know.
all these the esteemed professors who are, sticking to what I would say is dogma regarding low fat diets, and carbohydrate consumption, that it's a form of harm in many ways, because you're depriving the patient of what is obviously a best practice treatment.
Yeah, absolutely. And they are harmed. I'm waiting for someone to sue them. I've got a lady, her EGFR is 18, and she said, "Why if someone had told me this before, my kidneys would be fine." You know, she's the lady who went home and did the prawns in garlic butter. She was on insulin, off insulin. She's been doing it for 2 years now. But if she'd been told that 5 years ago, her kidney function would be fine. And people who are blind or had a renal transplant, or, it's because someone's skeptical. They're like the gatekeepers stopping the good news story getting in. And they are
And
harming, but they'll never apologize and they'll never be held accountable.
I'm very optimistic that things will change, and the truth inevitably comes out. So, um, I guess the doctors are presented with an option, especially when they see a patient that has had such amazing results like yours have, and they can decide to either ignore or rationalize those findings, allow the cognitive dissonance to overwhelm any type of introspection or concrete action, or they can maybe take a bit of a humble pie and ask themselves, why is this patient improved? What approach did they take? How can I incorporate that into my practice? I mean, to me,
Yes.
that seems like the two options that any doctor practicing today has. What do you think about that?
Well, I must admit, I'm being a bit mean because in the town that I'm in, the doctors are all amazing. So they really supportive. I
Mm,
get I gave a talk at the grand rounds at the hospital with the liver doctor here, the gastroenterologist, and he sends me his fatty livers because he can't believe how amazing it
mm,
is.
mm,
And so that's pretty supportive. And I gave that talk and they were great. And the intensive care specialist went, "This is fantastic. We should be talking more about this." So there are a few sort of skeptical questions, but mostly everyone was, this is interesting. And GPs send me patients. So the endocrinologist here sent me some patients. So they're actually good. So I'm being a bit mean about
mm.
them because there's a lot of supportive people.
That's
Um,
great.
I do think actually general practitioners are the ones that are going to bring this on because we're the ones sitting in that room getting murdered. We're just drowning. It's terrible. And patients are coming in suffering, and we're the ones that we're getting it dumped on us. The specialists might see them once a year. We're getting it every day. And once GPs start doing this, they're going to be so happy. And I'm thinking it's going to be a GP revolution. That's what I think. I think we need to just spread the word, let the GPs start doing it because we don't make money from prescribing pills. There's no incentive. There's that sort of theory, oh, our doctors are in it for the money. Well, I don't get any money for writing scripts. Um, it's much more fun to stop them. So I think we will find. That's what I hope. I hope the GPs are just going to start. It'll be like this epidemic, and it'll just start, and we won't care what anyone says because we see our patients getting better. So we'll just keep doing it.
Yeah.
But actually,
So,
there's a class of drug called an SGLT2 inhibitor that might be a problem. But anyway, I'll stop
mm.
talking.
No, that's okay. If you're able to give, so maybe if you have some advice for patients or someone who is overweight or has been told they have fatty liver disease, might have type 2 diabetes, maybe not yet medicated, or only on a drug like metformin, what would your be advice to someone who's considering a dietary approach to reversing their disease?
Okay, well, they should do a low carb dietary approach. What should they do? Watch Dr. Sarah Halberg's TED Talk. So that would be a good place to start if you've got diabetes or obesity, because that's very inspiring, and it'll help you fight back against people that tell you you're going to die and you shouldn't do it. Watch her TED Talk. Don't get caught up in the internet's full of rubbish. So people think they have to buy a ketone ester or they have to buy a supplement. You don't need a supplement. Don't watch Dr. Berg. Although some of my patients love Dr. Berg, so I won't say that. So you don't need a supplement, you don't need a pill. Watch Sarah Halberg's TED Talk. And even just the Low Carb Down Under website is enough. And also just watch Dr. Eric Westman's Adapt Your Life videos, which are fantastic. And his white coat video will tell you exactly how to do a low carb diet. And just start there. So Low Carb Down Under, perhaps the Diet Doctor website, Eric Westman and Sarah Halberg, and you can do it. If you are, and it's as simple as, this is Sarah Halberg, no grains, potatoes or sugars. That's it. Don't eat, and start with your breakfast. Get rid of your cereal, have an egg. You don't need bread on your lunch, so just have your chicken with your mayonnaise, but just don't use the bread. Use a lettuce leaf. You can still have, what do you normally have for dinner? Spaghetti bolognese? Great. You can still have the bolognese. Instead of the pasta, just get a lettuce leaf. The family's having tacos? Great. You can have tacos, but you just don't have the taco. You have the lettuce leaf, the meat, sour cream, everything else. Yum. Everyone's having pizza, just eat the topping, or get the garlic prawns at the restaurant. Just tweak what you do. Just pull out the white food. It doesn't need to be a meal plan or anything hard. And that's usually enough. Once you realize it's grains, potatoes, and sugars, you're done. You're cured. That's it. And if you start early, the easier it is. So if you wait till you're on insulin and your pancreas is dead, it's not quite so easy. But if you start right, you don't even need to go very low carb. You just go low carb and away you go. It doesn't have to be hard, and you don't need to spend any money. How's that?
And what would your advice be to, say, colleagues who are considering adopting or trying to begin practicing in a lifestyle and use therapeutic carbohydrate restriction?
Yeah. Similar advice, really. If you have to teach yourself what the patients have to teach themselves. There is a CME course on the Diet Doctor website for health professionals. It's free. Like, you don't get CME in Australia, but it's a series of videos for health professionals on the Diet Doctor website. And there are these apps available in Australia now, which I forgot to say, for patients, like what's Rob's app called? Diverso, is it?
So yeah, Dr. Rob Sabo's remote healthcare service is called Diverso. Yeah.
Yes. And then you've also got Defeat Diabetes app, so patients could do that as well. And for GPs, I would just go on the Diet Doctor website, do that little course, have a look at the Low Carb Down Under videos. It's like a university degree there. And also, I find Eric Westman is the best at explaining it for clinicians. He keeps it really simple, practical, and easy. He doesn't make it hard. You don't need all this measuring and ketones and how many grams of this and that. That's what he taught me, because I loved him because he made it easy. But all those Diet Doctor, Low Carb Down Under, Eric Westman, Sarah Halberg. That's it.
Great. Well, I'll include those links in the show notes of the video, so and listeners can check out those links. So thank you so much, Penny. I think you've really painted. I guess we painted a kind of bleak picture, but we've really painted an optimistic picture, and that is how exciting and how much is possible for patients who are plagued with chronic disease on a large number of medications. I think what you're doing is really giving people hope, and you're showing what's possible in terms of reversing these diseases and freeing themselves from a life of chronic disease and fatigue and prescriptions. So is there anything else that you'd like to end on, or how can people get in touch with you or follow you on social media? Can you give us a handoff?
Sure. I'm on Twitter at Penelope Figtree, always trying not to have arguments and have weekends ruined. And gosh, I've got a web page. What's it called? Low Carb PMQ. That's my web page, and Low Carb PMQ has also got a Facebook page. But that's me. But I do, people out there with these chronic diseases, just remember it's just intolerance of carbohydrates. That's your disease. It's a disease of carbohydrate intolerance, and it's easily fixed within days. You will be feeling better if you just pull out the carbohydrates. You do not need grains. God, nature didn't evolve with you eating a lot of bread. It was with a lot of animals and a few vegetables. All right. Thanks, Max, for having me on.
Thank you very much, Penny.
Okay.
Great.
Take
See ya.
care. Bye-bye.